Welcome back to the deep dive. Today, we are undertaking a very specific and incredibly detailed mission.
We certainly are.
We're dedicating this entire deep dive to the anatomy of the elbow and forearm, pulling our insights from, well, the deepest well of knowledge. A single chapter of Gray's Anatomy.
It's a big one.
It is. Our goal is to build a mental map, a perfect three-dimensional one of this entire region. We want to turn diagrams into descriptive soundscapes for you.
Right, so you can see the bones, the muscles, the nerves, all of it.
Without ever looking at a picture.
And the key phrase here is really structural paradox. I mean, that's what this region is. It's a study in engineering compromise.
On compromise, how so?
Well, it has to satisfy two fundamentally conflicting demands. You need extreme stability for the hinge motion of the elbow.
Flexion and extension.
Exactly.
Yeah.
But you also need incredible mobility for the forearm, for that, 180-degree rotation.
Pronation and supination.
Right. So we're going to focus on how that works, not just what the parts are, but how they relate to each other in space and why that matters when things go wrong.
Okay, let's unpack that, starting with the very foundation, the bones. The distal humerus, the ulna, and the radius.
Starting with the distal end of the humerus, picture a modified condyle. It's a little wider side to side and curved slightly forward.
Okay.
It's divided into two articular surfaces. Laterally, you've got the capitulum. It's rounded, convex. But the key thing is, it only covers the front and bottom parts of the bone.
So it doesn't wrap around to the back at all?
No, it stays clear of the back, but medially, you have the trochlea, the pulley-shaped surface.
And this one is different.
Very different. It's asymmetrical. It covers the anterior, the inferior, and the posterior surfaces. And its medial margin projects a little bit further down than the rest.
Ah, and that little projection, that asymmetry, is a beautiful insight into function, isn't it?
It's everything.
What does that slight downward angle actually accomplish for us?
That projection is what defines the carrying angle. When your elbow is straight and your palm is facing forward, your forearm isn't perfectly in line with your arm.
Right, it angles out a bit.
Exactly. That asymmetry guides the ulna to sit at that angle around 14 degrees in females, a little less in males. It lets your hand clear your hips when you walk.
That's fantastic. So the shape of the bone dictates the arm's resting position. Now, what about the rest of the humerus? There are those three depressions, the fossa.
Right, the bony stopping mechanisms. Posteriorly, you have the deep olecranon fossa.
Which is essential. It's what catches the tip of the ulna when you extend your arm.
Right.
Stops it from going too far back.
Precisely. It just swallows the tip of the olecranon process. Then anteriorly, you have the smaller coronoid fossa for the ulna's coronoid process during flexion.
And a third one.
Slightly lateral to that, the radial fossa. It's just a slight depression that accommodates the edge of the radial head in full flexion.
Okay, now let's look at the ulna, the medial stabilizing bone. When I picture it, I just imagine a massive stable hook.
It is a hook. That's a perfect description. And that hook is made up of the palpable point of your elbow, the olecranon process.
The bit you lean on.
Exactly. And the deep trochlear notch that lines the front of that hook. This notch just perfectly cups the humeral trochlea. That's where the incredible stability of the elbow comes from.
That bone-on-bone fit.
That's it. And then just on the lateral side of the coronoid process, you find a small, smooth surface. That's the radial notch, where the radial head pivots.
Which brings us to the radius, the lateral bone, the one that spins.
Right. Proximally, it starts small. You have that discoid radial head that articulates with the capitulum. And just below the neck, you find the radial tuberosity.
A key landmark. Insertion point for the biceps tendon.
A vital landmark.
Yeah.
And if we jump down to the distal end, the radius expands. It gets much wider. Posteriorly, it has a very prominent, palpable bump, the dorsal tubercle, or Lister's tubercle.
And that's not just a bump, it's a functional pulley.
It's a fulcrum for the extensor pollicis longus, a key thumb tendon. It redirects the line of pull.
And distally, the articular surfaces for the wrist.
You have two facets, the medial lunate fossa and the lateral staphoid fossa. The radius really carries the load from the hand, about 80% of it.
That load sharing is a perfect lead-in to the ligaments. We have this complex of hinge joints and pivot joints allowing a huge range of motion.
And stability is all about the collateral ligaments. On the medial side, we have the incredibly robust ulnar collateral ligament complex, the UCL,
Triangular.
triangular, and its job is to resist valgus strain. That's the force trying to push the forearm away from the midline.
And the anterior band of the UCL is the star player, right?
It absolutely is. It's the strongest, stiffest part, and it stays tight through almost the entire range of motion.
And on the lateral side.
That's the radial collateral ligament complex, the RCL. It's more of a flexible sling, and a key part of it is the annular ligament.
Which is like a little belt for the radial head.
It's a fibro-osseous ring that just locks the radial head into the ulna's radial notch. It lets it spin, but it can't escape.
So that keeps the pivot joint in place.
Yes. And then you also have the lateral ulnar collateral ligament, which is critical for preventing posterolateral dislocation.
Okay, moving down the shafts. The two bones are connected by...
The interosseous membrane.
Yeah.
A broad sheet of connective tissue. And its fibers run obliquely, mostly from the radius down towards the ulna.
That oblique angle is so important.
It's essential. It provides longitudinal stability. It stops the radius from, migrating proximally, especially if the radial head gets fractured.
Which links directly to the stabilization system down at the wrist. The distal radio-ulnar joint, or DRUJ, and the Triangular Fibrocartilage Complex. The TFCC.
The TFCC is like a strong, complex shock absorber.
And a stabilizer. It suspends the distal radius from the ulna and is vital for load transfer. But here's a crucial detail from the anatomy.
The blood supply.
Exactly. Only the outer 15 to 20% of this thing is vascularized.
Which means an injury to the central part is incredibly difficult for the body to heal on its own. It just doesn't have the resources.
Right. So let's move from the deep structures to the more superficial, the functional space in front of the elbow, the cubital fossa.
Okay, so picture a triangular depression.
Its boundaries are key. Proximally, it's bounded by the line between the epicondyles.
Medially, by the pronator teres muscle, and laterally, by brachioradialis, and running right down the middle is the tendon of the biceps brachii.
And the contents of this fossa are an anatomical goldmine. They tell you exactly what's at risk in trauma. So going from medial to lateral, what are the big three?
We use the mnemonic MBR. Medially, you have the median nerve, then the brachial artery, which actually divides right here into the radial and ulnar arteries, and finally, laterally, the radial nerve, which also divides right there into its two main branches.
RMBR. Perfect. Now, the rest of the forearm is organized into these distinct compartments.
Right. Created by tough fascial sheets. You've got the anterior flexor compartments, a posterior extensor compartment, and then this specific group called the mobile wad.
The mobile wad of Henry. I love that name. It's a great landmark for surgeons.
It is. It's a group of three muscles, brachioradialis, and the two radial wrist extensors, ECRL and ECRB. They define that lateral border of the forearm.
Let's talk about the engine room then, the muscles, starting with the anterior or flexor compartment. That's where the gripping power comes from.
And these are mostly powered by the median nerve.
Mostly, but with two crucial high-yield exceptions.
Classic exam question. The flexor carpi ulnaris, or FCU, and the medial half of the flexor digitorum profundus, FDP, are both supplied by the ulnar nerve.
And in that superficial layer, let's talk about pronator teres.
It has two heads.
And the median nerve has to thread its way right between those two heads, which immediately signals a potential problem area.
A classic entrapment site.
Right.
Deeper down, the flexor digitorum profundus, or FDP, is the one that flexes the tips of your fingers, and its dual innervation is unique.
Right. The lateral half gets its nerve supply from a branch of the median, the AIN.
And the medial half gets its supply from the ulnar nerve. It's a beautiful illustration of how the arm develops.
Okay, let's flip over to the posterior, or extensor compartment. These are generally supplied by the radial nerve, or its deep branch, the posterior interosseous nerve, PIN.
And it's worth pointing out that brachioradialis, part of that mobile wad, is actually a powerful elbow flexor.
Even though its name sounds like an extensor and it's in the lateral compartment.
Right, and it's strongest when your forearm is in that neutral mid-pronation position, like holding a glass.
And deep in the back, we find the long thumb muscles.
Abductor pollicis longus, extensor pollicis brevis, and extensor pollicis longus. APL, EPB, and EPL.
And these three tendons define that little triangular depression on the back of the wrist.
The anatomical snuff box.
Yes. Okay, we built the structure, installed the engine. Let's trace the highways. Blood and nerves. Where are they vulnerable?
Let's start with arteries. As we said, the brachial artery splits in the cubital fossa into the radial and the larger ulnar artery.
And the ulnar artery dives deep.
Immediately, it plunges deep to supply the flexor compartment. But crucially, the elbow joint has this amazing web of collateral circulation, a network of branches that ensures blood flow even if the main brachial artery is blocked.
A built-in backup system.
Exactly. And the common interosseous artery comes off the ulnar and divides into the anterior and posterior interosseous arteries, which travel with their namesake nerves.
Okay, now for the nerves. This is where those spatial relationships really become critical. Let's start with the median nerve.
The median nerve runs deep to the bicipital aponeurosis and is immediately vulnerable as it enters the forearm.
Because it has to squeeze between the two heads of conator teres.
Exactly. It then continues deep, running between the superficial and deep flexors. And its motor branch, the AIN, is key for your pinch strength.
Now, the ulnar nerve. It has a notorious course.
It runs right behind the medial epicondyle, your funny bone. You can feel it right there. It's very exposed, very vulnerable.
And then it enters the forearm by passing between the two heads of the muscle it supplies.
Flexor carpi ulnaris. And that passage is the cubital tunnel, another major choke point.
And finally, the radial nerve.
It divides near the lateral epicondyle into the sensory superficial radial nerve and the motor posterior interosseous nerve, the PN.
And for the PN to get to the extensors in the back, it has to pass.
It has to pass between the two heads of the supinator muscle.
Which is a classic anatomical pinch point. So let's use that to talk clinical correlations. These choke points lead to specific nerve entrapment syndromes.
Absolutely. The PN gets entrapped as it passes under a tight fibrous arch at the top of the supinator, the arcade of Frost.
And that causes motor weakness, trouble extending the wrist and fingers.
Severely affects them, yes. For the ulnar nerve, the most common spot is that cubital tunnel, often from the fascia tightening up after repeated elbow flexion.
And for the median nerve,
compression is often as it passes through pronator teres, causing this diffuse forearm pain. But the specific anterior interosseous nerve syndrome, or AIN syndrome, is distinct.
how so?
It results in the failure of the OK sign, that fine pinch grip, because the thumb and index finger flexors are weak.
Fascinating. Let's wrap up with the major traumatic injuries that show how all these structures can fail together.
Well, the stability of the forearm depends on the radius and ulna staying together, so we see patterns. The Montagia fracture dislocation.
That's a fracture of the proximal ulna, combined with a dislocation of the radial head, proximal instability.
Exactly. And the reverse pattern, distally, is the Galeazzi fracture dislocation.
So that's a fracture of the distal radius with a disruption of the DRUJ, the distal joint.
Correct. And then there's the most structurally devastating one, the Essex-Lopresti injury.
This is a catastrophic failure of that interosseous membrane.
Total failure. A high-energy fall fractures the radial head, ruptures the membrane all the way down, and dislocates the DRUJ. The whole radius just migrates proximally.
An incredible cascade of failure. This has been an incredibly detailed deep dive.
It's a lot to take in.
It is. But if you remember the essentials, the humerus is asymmetrical trochlea, defining the carrying angle, the critical stability from the UCL, the MBR contents of the cubital fossa, the unique dual innervation of the FDP.
And those three classic nerve entrapment sites, the pronator teres for the median, the cubital tunnel for the ulnar, and the arcade of Frost for the radial nerve's PPM branch.
It paints a very clear picture.
I think the ultimate takeaway is that while the bones provide this foundational stability, the forearm's ability to rotate is maintained by these flexible, sometimes fragile, joints and membranes. A simple fall can cause this chain reaction of disruption from elbow to wrist. Which leaves you with the question, really.
What's that?
Considering how critical time is when dealing with trauma involving these nerves and vessels, how close are we to developing real-time, intraoperative imaging technology that can instantly assess the viability of these vital structures during an emergency fracture reduction?
A fascinating point to consider as medicine advances. Thank you for joining us for this deep dive into the complexity of the elbow and forearm. Keep learning, and we'll see you next time.